Good afternoon, everybody. You're all very welcome to this afternoon's live webinar, QPS TalkTime Special, live from the International Collaborative Workshop here in the Department of Health. And today's topic is Measuring Patient Safety Performance, International Insights to Support Healthcare Reform. So moving on, I would like to introduce you to my colleagues here who are very kindly joining us for the webinar today, and we're very privileged to have Dr. Shaikh, Dr. Ulfat Shaikh, who I'm going to ask to introduce herself now.
Great, thank you so much. I'm so excited to be here. My name is Ulfat Shaikh. I'm a practicing pediatrician at the University of California, Davis, and also serve as the Director for Quality and Patient Safety there.
Thank you, Ulfat. And we're also joined by Dr. Anu, who's very kindly allowed me to abbreviate her name. So if you wouldn't mind introducing yourself.
Thank you. I'm Dr. Anuradha Pichumani. So I'm basically an obstetrician gynecologist. I run a hospital in India, in the southernmost part of India, and more into patient safety and quality, and on the ISQua board now. Thank you so much. I'm very happy and excited to be on this QPS talk series.
Thank you very much, Dr. Anu. And Louise McGirr, if you would.
Thank you very much, Orla. I'm Louise McGirr, and I work in the Department of Health, and I am head of the resources area in health, which really deals with the health budget, health workforce, and I have overall responsibility for performance oversight, performance management across health. So, and that's, I suppose, my connection. Unlike the other speakers here today, I'm not an expert on patient safety, and many listening will know a lot more than me. So I've learned a huge amount today about patient safety, but my particular interest is how patient safety is, how it is measured and how we focus on improvements in patient safety across the system from a system view. So thank you very much.
Okay, thank you very much. Thank you all for that. So what's this session about? So today we're looking to explore strategic and practical approaches to measuring patient safety from an international perspective. We're going to hear lessons in patient safety and staff engagement for quality and patient safety, and we're going to examine learning from patient safety collaboratives, in particular with a lens on community setting as we move towards integrated care as part of SLANT care implementation. With the help of our international colleagues here, we're going to share tools to improve the sustainability of patient safety projects. So, without further ado, I'm going to hand over to Louise to make her presentation. Louise?
Okay, so thank you very much, Orla. So in terms of this morning, I think I'm just going to give a summary of this morning and how it went, some of the key takeaways from the morning, and I think where it points us for the future. So my specific focus is where we are at the moment in HSE, particularly in Ireland's public health system. And my colleagues will speak much more knowledgeably about learnings from abroad and how they can be applied here. So the day and the morning covered a broad range of experiences, I would say, and views on how we measure performance in the health sector. And I think what I took from it was a sense of us clearly engaging and trying to measure performance and having information on performance, particularly in our acute settings, but with potentially a lens of kind of individual sites, individual areas, rather than a broad knowledge of how we're performing in relation to patient safety. So my experience on the management board, for example, in health, is very much being aware of particular patient safety incidents that are very significant, as opposed to, are we very strong in terms of patient safety in Ireland? What do we define as patient safety in Ireland? So what are the key components? What makes a patient safe in Ireland? And the day really covered for me, we're in Ireland at the moment, we're looking very much at the acute system, we're looking at critical incidents and serious things that happen in those settings, and sepsis and other things. But this may be untapped area of the community where potentially patient safety is not, we're not measuring it, we don't have good visibility on it. And things like our waiting lists, our inability to access care, they're all part of the patient safety picture that maybe we don't have as good visibility or understanding of in terms of the impacts of that on safety. So the other, I think, big focus of the day was around how technology can really drive and lead and help us to create a safer patient and better quality care, and also how much we can engage carers, the community, patients themselves to actually drive. So you've got this push-pull, I think it was maybe one of your slides, and I really liked it, this push-pull of improvement coming from the system, so to speak, or the healthcare workforce and the systems in which we operate. And then how, by allowing access and giving, better health literacy to our public, to our carers, ensuring they know what to do and what to look out for in simple terms, how that connection and relationship can really improve and work together. So I think that was a big takeaway from the day.
Yeah, thank you very much, Louise. I think it was very interesting for us to hear your perspective at the core of measuring and assessing performance and seeing the return for the investment that you're putting in at your level. And it was an opportunity for us in this delivery system in Ireland, and also for our international colleagues, to speak as to how we see patient safety and quality performance ought to be measured, and make those comparisons internationally. I think it was certainly beneficial for us to have your perspective on it, and I think that you gleaned quite a lot of insight from our perspective, and I think it was very telling. And I think we need to reflect on how we managed to convey our requirements to you, and what best practice in measurement for patient safety is internationally.
Yeah.
Okay, so thank you very much for that, Louise. A couple of questions. Have we time for a question or two from the chat box? I think we might have to save those to the end. So I am now going to hand over to Dr. Anu, who fascinated us this morning with her insights from India. So I hope you enjoy her presentation as much as we did earlier. Over to you now.
Thank you. So I shall just give you a brief presentation on the strategic approach for measuring patient safety. These perspectives are from LMIC, and so we go through these standards where you need to talk about standardization. The agenda will be like you have to have standardization across hospitals. You need to contextualize what data are you going to collect based on the priorities. So you need to prioritize what you're going to do for patient safety within each organization. And then you do a capacity building with your staff and understand how you're going to utilize the local data to improve the patient safety in your own departments or in your hospitals. Then to reduce human errors, you need to have various barriers, checks in place. And I will talk more about the collaboratives, how you can use it to improve patient safety. And again, sustainability of quality collaboratives and something on patient engagement. So moving on, the quality collaboratives are groups where we take up groups of hospitals to improve the quality across organizations. And we have a huge amount of learning and sharing in these organizations. So we did a collaborative on using the Safe Childbirth Checklist. This, we were able to use this collaborative in LMIC, where we were able to take the hospitals through the design phase, where we were able to integrate it into the QI initiative, get feedback, and then engage the teams, and then launch the Safe Childbirth Checklist in their organizations to improve the labor room safety. And then we were supporting them through two PDSA cycles. And we were able to see the PDSA improvement and the initiative. So this is the PDSA 1 and PDSA 2, where you are able to see the improvement
Okay. So you've mentioned and you've given some examples about involving patients, and could you maybe speak a little bit more on how patients were involved in the co-design of those projects?
Okay.
I'm very struck by how similar your approach, in early warning scores and PDSA cycles is to our own, and I'm keen to know how you fare in co-design with patients.
Okay, so thank you for that. So in co-designing, we took up the UK Tool Fund Kit, the experience-based co-design project, and we were able to design certain things like we had a facilitator. We trained the facilitator on how to interview the patients as well as the staff. So we had a team of staff members talking to the facilitator, and based on these interviews, we were able to collect and edit these interviews. And then the whole group sits together and sees whatever the interview has been done. And then they start prioritizing what has to be the changes which has to happen within the department. So after the prioritization happens, then we have teams where you have the staff as well as the patient sitting together, and they redesign the whole process within the department. So when the whole team is involved, the complaint starts improving rather than we pushing it from the top leadership or from the quality team. If the team themselves get involved and start redesigning the process, your compliance on patient safety improves. That's how we were able to do the experience-based code design.
Excellent, excellent. So another challenge for us is how we involve the community or advocacy groups and the like. Do you have such issues in India, or how do you engage with your community in regard to patient safety in particular?
Yeah, this community engagement becomes very important, more so in low middle income countries like India, where you have a huge amount of patients to be taken care of. So it's more than 1.4 billion population, which we are talking about in one single country. And that's the reason we try involving many people into the caregiving programs. So in our hospital, we started the Patient and Family Centered Advisory Council. So we were able to take up patients who themselves had some lived-in experience of getting into the care system, and they were able to give us their perspectives in improving many of these projects, what we have been talking about. So we do the community engagement by going in for free camps, doing community programs within the villages where the literacy rate is very low. So to empower them, we utilize this community, this patient and family centered organization, where they help us to educate the patient attenders. And again, we are able to improve on the feedback mechanism. Whenever we get feedback within the hospital, it can be the feedback from the OP patients or the feedback from the inpatients. So we put up the feedback and discuss among the patient and family centered advisory committee members, and they give us various insights which we don't actually think about. So those are very new initiatives which we are able to implement based on this committee people. And again, we have been involving this committee in various other activities, like we have started a senior citizen club in our organization, since we take care of huge amount of diabetes. Diabetes is a huge problem in India. I think India is the diabetic capital of the world now, with a huge amount of chronic care illness coming up. And so for all these chronic care, we need to engage the community. So we are doing various projects. Patient and family centered committee members into these projects, where they start empowering the patients. They help us in redesigning the process in many of these initiatives.
Wow, we've a lot to learn there, and it really gives great meaning to community engagement. And I just have one last question that I have to ask you about your involvement with Harvard and your work with Adrian Labs on sustaining QI. Would you care to share your expertise and knowledge there?
Yeah, definitely. So I was very happy to partner with the REnga Labs, which are part of the Brigham Women and Children Hospital and the TH Chan School of Public Health. So I was partnering with them in implementation of the safe childbirth checklist first in our hospital, and then based on the experience of PDSA cycles which we took up, and the implementation which we were able to do in our hospital, I started out with a QI collaborative with 9 other hospitals. After the implementation, because REnga Labs had done a previous study that was 5 years back in Uttar Pradesh in India. It was the largest study of maternal and newborn, where they were trying to implement the safe childbirth checklist in all the public hospitals in Uttar Pradesh. But even after they had implemented, they found out that each hospital differs because the context changes within the organization, and they were not able to sustain it because one hospital, it is about the resources. Another hospital is about the training part. So based on this context, again, many of the projects are not being sustained. So REnga Labs have come out with a toolkit, which is called the Context Assessment Toolkit, which we call it a CAT, where you have a pre-implementation survey where you are able to find out what are the whether the hospital is ready to take up a QI project. That is the first thing you need to check. Whenever you're going to implement a quality improvement project in an organization, if the hospital itself is not ready, then if you're going to take up that, then it will fail. So you have these various toolkits where you have a pre-implementation survey to check the readiness of the hospital. Then you have a post-implementation survey. And again, you have this conversation guide, which we are able to help the hospitals to sustain this any QI project. It can be used for anything, but I was specifically using this as a pilot in our hospital for this safe childbirth checklist implementation. So after we implemented the safe childbirth checklist in our hospital, in all the 9 hospitals, it was at 97 to 98%. And then we implemented this conversation guide. We talked to the leaders of the organization. We involved the leaders and the staff members within the organization. And based on the conversations which we had, and all this was during COVID, so we had to take many of them on Zoom calls and other things. But in spite of challenges, we were able to find out what were the challenges within each organization individually. And again, we were able to find out the strengths of that organization. So based on that, we were able to give individual action plans for each of these 9 hospitals. And all the leaders took it upon themselves to work on these action plans. And they were able to sustain the project even after 6 months of implementation. So this is the way the context assessment tool helps in continuing any implementation on any QA project. And I can share with you the link where it's all freely downloadable from the REnga website, and I'll be able to share with the QPS team also.
Such an elegant solution, so meaningful. I have to be doing it all the time, one asks. So thank you very much for that. And in the interest of time, I am going to hand over to our colleague, Dr. Ulfat Shaikh here, for your presentation.
Thank you so much. So I was asked to reflect on patient safety measurement in the United States, and I am humbly offering a perspective here for you to consider. So I was trained in pediatrics in New York, and that was about a couple of decades ago. And that was a really important time in the world of quality improvement. When I was a second-year pediatric resident, the book To Err is Human, the report was released by the US Institute of Medicine, in which they basically shared with the country that we were killing 100,000 patients a year due to medical errors. So a really staggering number. It was quite a shocker. And as with improvers, as improvers do, when you come up with a problem, you chase that up with a solution. And a couple of years later, the IOM, the Institute of Medicine, released a second book called Crossing the Quality Chasm, in which they laid out a framework for improvement for the nation to help prevent medical errors. So despite there being a couple of decades between the release of that report and now, there still is a huge gap in what we do and how we can make things better with respect to patient safety. And when we look at statistics in the United States, here are the rates of all-cause mortality in the United States. And heart disease and cancer are big, but the third largest cause of death in the United States is actually medical errors. So think about that for a second. We in healthcare should be helping patients and not doing harm. And instead of that, medical errors are the third leading cause of death in the United States. So really staggering numbers there. And when we look at patient safety issues in primary care, so I'm an outpatient general pediatrician. I cover our clinic and urgent care a couple of days a week when I'm not doing quality improvement, research and administration and teaching. But annually, 1 in 20 outpatients experience a diagnostic error in the United States. 55% of patients said that diagnostic errors were a chief concern in outpatient visits. 1 in 9 emergency department admissions are related to an adverse drug event. And an estimated 160 million medication errors occur each year in primary care clinics. Now, when you couple all of those really shocking numbers with the fact that up to 80% of information that we share with patients in primary care settings is immediately forgotten, you can think about the complexity in outpatient primary care and why that might lead to all of these issues of medical errors. All of these problems were exacerbated in the last few years by the COVID pandemic, which, it's been clearly shown that during that time, medical errors increased, preventable adverse events increased, but there was also quite a bit of innovation that stuck. For example, outpatient primary care started adopting primary care video visits. In the US, for years, we've been doing video visits for specialty care, but really there was minimal uptake in the primary care clinic setting, and that really escalated and has been adopted quite well. So there were a lot of safety issues, but there are also some opportunities that we identified. So for years, we've had patient safety goals and metrics in the inpatient setting. But in the last few years, an advancement that I'm really excited about being an outpatient doctor is the patient safety goals and measurement in the outpatient setting. So inpatient was something we've worked on for several years, but now we've started really looking at the science of improvement in the outpatient setting and improving patient safety there. So making sure that we identify patients correctly, that we perform adequate hand hygiene, there's medical safety, there's procedural safety. All of those measures have now been adopted in primary care clinics, and people are tracking these. So really excellent advances with outpatient improvement. There is a national action plan to advance patient safety in the United States called Safer Together. And I wanted to go over highlight some of the aspects of the patient safety plan that are relevant. With the patient safety plan, there is also this self-assessment tool that clinics and organizations can complete before they look at how they might move toward improvement. So with respect to the patient safety plan, before I move into all of the patient safety indicators in the inpatient setting, some of the things that you might find that we have in common is a focus around leadership, a focus around teamwork and communication, making sure the staff are engaged in improvement, and that we have a learning health system. So what I wanted to highlight with this next slide is that for years, we've been tracking patient safety in the inpatient setting. And when we look at patient safety indicators, all of these are inpatient. But then now we've started paying a lot of attention to patient safety and outpatient care. Outpatient care is an area where lots of issues can occur. There's lots of potential for errors. There's potential for missed or delayed diagnosis and medication errors. Some of the unique considerations that exist in clinic settings that patient engagement is somewhat more challenging. When you have a patient in the inpatient setting, all the caregivers are around them, they actually surround the patient and can work with the patient right there in that same geographic location. But in the outpatient setting, patients are left to self-manage their chronic conditions, give themselves their medications, keep track of medication doses, track of side effects. There are issues around health literacy, making sure patients understand the information we communicate to them, problems around care coordination, clinician communication, transitions of care between the inpatient and the outpatient setting, and issues around telephone advice or video advice, and making sure that is delivered in a safe and clear and memorable way to patients. It's also issues around safety culture. You have typically in outpatient clinics a pretty heavy workload, which could lead to dissatisfaction and burnout, which then has direct implications on patient safety. So improving safety in the outpatient care, I've been a practicing pediatrician for about 25 years and have seen the advances in safety in outpatient care. So electronic health records traditionally been used in the US for making sure we document well for billing and claims, but now are being used to improve patient safety, by helping reduce medication errors, right? So when we input prescriptions into the EMR, there are alerts that go off if we have too high a dose, too low a dose, if there's allergic reactions that could happen, if a patient has an allergy we've missed looking at, we can track test results. The shared electronic health records, for example, a platform in the US has this functionality called Care Everywhere, where it's an interoperability platform where if I see a patient that that's been seen at another emergency room in our community, I can actually pull up their records and see what happened there and how the emergency room course was. There's electronic ways to improve patient engagement through electronic health record patient portals, which gives patients access to their advice and test results and helps them ask questions electronically versus trying to play phone tag with their doctor. Some of the other advances that I think are really positive are these surveys on patient safety culture. There is, as a couple of the other speakers mentioned, really important for leadership to be engaged in patient safety. And really what leaders say and what leaders do might differ. And really these surveys of patient culture are a way to see if the culture of quality is promoted in our healthcare organizations. And so I just wanted to point you to this resource. There are safety culture surveys that we have that are customized to the inpatient, the outpatient setting, nursing homes, community pharmacies, and ambulatory surgery centers. And then really, we've seen over the past decade and a half, measurement strategies move from collecting retrospective data through chart reviews, incident reporting systems, billing data, to now moving into prospective data collection in the form of digital quality measures, and then moving from just collecting process measures, what are we doing, how many times are we doing things, to outcome measures, what matters to patients in the end, how healthy are patients, what is their health-related quality of life, what's mortality, what's morbidity, things like that. So to give you an example of digital quality measures that are prospective and outcomes-based, here's one example. This is the severe hypoglycemia measure. Talks about, it basically looks at patients who experience a severe hypoglycemic incident and basically indicates avoidable adverse drug events. And so what this does is pulls data from the electronic health records, lab data, and it measures the number of patients who administered at least one hypoglycemic medication during a hospital stay and subsequently had a severe hypoglycemic event. So this is a really good example of using outcome measures and prospective data where there are no humans actively working to collect the data, but we're using our technology to produce that data in a way that we can digest it really well. We also have national quality reporting programs, and these are really important to benchmark care and really to hold organizations accountable for providing safe care to patients. They're really important for transparency. So we do have a quality reporting system that patients can access. And this is through the Care Compare website. And so our government has a website where you can actually go in and find and compare hospitals and that are near you and look at their performance on safety measures, compare performance of to the 2 or 3 hospitals that you may have in your community or the area around you. And basically, it allows the public to compare healthcare data based on quality and safety for home health services, inpatient hospitals, long-term care hospitals, etc. And so really some of the directions that we've taken in the world of quality are really positive, moving from retrospective data to prospective data, reducing the burden of data collection and making sure that the data we do produce is really usable by frontline clinicians and patients.
Well, that was a very quick run through, quite a sophisticated system. And thank you very much for that. I'm very interested to know if you could share your experience on how you engage other clinicians. You're clearly an early adopter here yourself, and championing the cause, but how do you involve other clinicians who may not be quite of that leaning?
Yeah, and I basically was convinced that quality improvement was a direction that I wanted to take and a part of healthcare that I wanted to incorporate into my practice. As I mentioned, historically, the historic roots of my interest were the quality movement that emerged as a result of the 2 Earths human report. And I've been working with clinicians on quality improvement for the past couple of decades. And one thing I've learned is a key to getting clinicians engaged is to tap into intrinsic motivation and not rely on extrinsic motivation. So what I mean by that is for years we've used the carrots and sticks approach where we've levied fines on people when they do things wrong, and we've punished people, and we've this individuals who've lost their jobs. And then we've moved to the carrots approach where we have pay for performance programs and salary incentives if you do the right things, and really moving away from those external rewards and punishments and tapping into why clinicians do what they do is key to getting clinicians engaged. So, the clinicians I work with, the vast majority of them are in the business of healthcare because they want to help people, right? They want to advance health. They want to help people, and they want to come to work and do a good job. And really positioning your quality improvement initiatives that highlights that spirit is really key. So starting off with patient stories, sharing data. So, you need to combine stories with data when you position your quality improvement initiatives to engage clinicians. There's always going to be skepticism about data. So acknowledge that, and, acknowledge that data collection and quality improvement is muddy. So people don't get hung up on that essentially. And then tapping into intrinsic motivation by showing clinicians how the initiatives we're trying to implement are actually going to help their patients and make life easier for clinicians, right? They're already overburdened. So if you have an efficiency initiative showing how that can help, or keeping patients healthy helps in general. So I think that's been the key to getting clinicians engaged.
Excellent. Thank you very much. And if I have just time to ask you one last question, you've been involved in a lot of national collaboratives in teen mental health and substance abuse as a pediatric obesity indeed as a pediatrician. Could you share some insights based on your experience there?
Yeah. So I've actually led several quality improvement collaboratives in a range of different areas, ranging from pediatric nutrition to the latest being teen substance use disorder and mental health. And this just working together with other clinicians on quality improvement work, I find is really energizing and helps clinicians basically just we understand that we need to help patients, but they see another way of helping patients is improving care in their practices. I always learn a lot from the quality improvement collaboratives I lead, and clinicians share that not only did they learn about the disease state or the condition, but they actually learned about how to handle clinic dynamics, how to communicate with their clinics, how to change workflows so that things work better for them, how to keep measuring and tracking data in a way that's less burdensome for the clinic. So yeah, I think QI collaboratives, generally have been pretty effective. The one thing I'd like to add is when the QI collaborative goes away, and Dr. Anu mentioned that, how do you keep improvement going? And that's what I think that first point I brought up is making sure the collaboratives tie into not just something we need to do as a project, but like, again, tapping into intrinsic motivation, like you're doing it because it's improved care for your patients and for yourself.
Excellent. Thank you so much, and thank you to my colleagues, the other panelists. So I think we've got some time now for some questions from the chat box. So Dr. Anu, I might start off with yourself there. You've been involved in collaboratives also. Would you like to share some of your learnings specifically from those collaboratives?
Yeah. So collaboratives, we have some various organizations who become part of collaboratives, and each organization is different. So this collaboratives gives you a structured pathway, and they take up one specific part of quality improvement to do this. And again, we can use some quality tools to run these collaboratives. So when you're going to select hospitals for collaboratives, you need to identify what are the challenges in these organizations. You need to identify the leadership, whether the leadership is motivated to become a part of the collaborative, and have a multidisciplinary team from each hospital. Then only it starts functioning. So this is the way you take up, you first identify organizations for this collaborative, and they all need to work on a common goal to implement a specific part of this quality initiative. And then moving on, you need to keep the team motivated. So identify some quality champions within each collaborative, within each organization, so that quality champion will keep the whole team motivated. And then use some quality tools like PDSA or whichever tool you want, you can use it. And collect data. The data collection is important. Understand the data, how you're going to analyze the data, see whether the collaborative is working properly, and then move it on. Whenever it's a collaborative, it's a fast learning, because you're going to learn from each and every organization. So you learn the challenges of that organization, and you start implementing certain things in the other organization. So it's learning and sharing part of it is very important in a collaborative, and that's how the fast implementation also works. So these are things where you can utilize in running collaboratives. Yeah.
Okay, that's fascinating. If I could just ask you, you said a lot about tapping into intrinsic motivation. Do you find time as a factor in busy schedules, or do you have any gems of wisdom as to how to cope in that environment?
Yeah. So
particularly with clinicians.
Yeah, time is definitely a problem. It comes up in every cause and effect diagram that we draw about issues that we need to tackle, the time constraints. And I think one way to mitigate that issue is to involve interprofessional teams in practices. So not everything related to quality needs to be done by the physician, right? They are surrounded by a highly capable team of people who know how to do a great job in the specific area they work in. So, for example, engaging, the nurses have been engaged in collaboratives traditionally, so that's that's been done. But thinking about other partners, right? Your front office staff, the medical assistants who room your patients, the pharmacist who works down the hallway, just making sure you engage the complete clinical team in your initiative. And we've done that with front office staff helping us with screening tools, right?
Okay.
So yeah, that would be my advice.
Okay, fascinating. Okay, so just as we draw to a close, Louise, we've heard a lot from around the world at this stage. So where to from here for us?
So I've been reflecting on this all morning, and I think the colleagues here have described a very collaborative and engaged process towards a way of working which gets to identify what are the key things that impact on patient safety, what matters in terms of patient safety, because what's going to really make a difference to patients. So I think we need to start at that point in what improvements in healthcare will be most impactful in terms of improving patient safety. What are those things? Then how do we measure them? And obviously that first point has to start with patients and the view of patients and what's going to work for them. How do we measure that? And we need to not over measure. We need to be clear on what the outcome, how that will be visible to us from an outcome perspective. So how will we know if a site or a region is improving in this area, for example? And then you can allow a very significant like kind of flowing down of creativity and innovation at site level for them to understand how they're doing in relation to those things, and to understand how they themselves as a team can engage on improving their performance or their safety quality. And so we need to work on a way to make it visual, usable, to give insight from the information, the data that we collect, and enable and support teams in improving through learning from each other. Peer learning networking is hugely impactful, actually. And we've struggled, I think, from an implementation perspective in health in Ireland to scale up where we have good practice, to shine light on what's good and to say, why aren't we all doing this? But why aren't we? I don't know. Do you know what I mean? Like, I can't answer it properly. So I think then the next steps and some of the things that people have touched on are around the key enablers. So I've said kind of what I think we need to do, but to enable those things, technology is huge. That's come out time and time again. And EHR being a big one. To keep it light on frontline staff, so not to have them inputting things and adding to their day in terms of data collection. The system should be doing that for us now. Things like standardized practices, improvements, etc., all really important. And the big piece around culture and leadership and engagement of staff. And I think there's a piece there for people who work in safety, in quality and safety care, to view it as the most important thing. And it is. I get that and I see that. But that for that to matter to leadership, why does it matter to them? And that is a piece of external communication that I think needs to come from within patient safety to speak to leadership across health systems, to politicians, to everybody involved in decision making and funding decision making and things. What are the impacts? Why does it matter so much? And what are the benefits that can be got from it? And it's the same approach with engagement, I think, with staff. So I think that the RHAs provide us with the perfect opportunity now, the new regions, to look at this afresh. We've got lots of things in. We are measuring lots of things, that's for sure. So to try and bring the things that we're measuring, the way that we're working together to strengthen these components that we're working as a whole, to reach into the community and not just measure what we can see, measure what's really important, and have the system, if you like, all working in the same direction, because we know what really matters and we know what is important to us in terms of patient safety, and allow creativity, flexibility, engagement within that. and continuous improvement. Small order.
I was sure looking
We'll
forward
do that
to
next week.
how you get on with that there. We have a couple of minutes for one or two more questions from the chat box. And Dr. Anna, you very kindly told us about how you work with communities and how you had your workers in the communities and getting the feedback there. Could you just touch briefly on your hospital's experience of using families and patients as part of committees in the hospital setting?
Okay, so getting these patient attenders or the family members into the committee is always a challenge. So we need to understand whom you're going to call them into the committee. And then they have to understand their roles and responsibilities, because it's not going to be a complaint committee. So they are going to work along with us, along with the system, to improve the system. So we need to make them understand why they are into the committees, and then get a consent form from them also, that they're going to be part of this committee, about the confidentiality and other things. And then we start working with them. And when you're inviting any person to be part of this committee, again, these are patients who have lived in experience, as I told you. And again, you need to, they also will fall sick on and off. So you might need to consider that and then have them, because they need to spend some time for the committees again. So then you start engaging them, and then start working with them on various projects. So we have done projects on the community level, where we have taken the birth companion project. I can give you the example for labor rooms, where we were able to empower the attenders who come with the patient. So we identify a birth companion. Usually in India, it's mostly the mother or the sister who has already delivered. So most of the family members are around. Like for each delivery, we have more than 5 or 10 people around for one delivery. So we have to counsel them, and then we identify one person as the birth companion, and then empower them. So we teach them what they have to identify as the early symptoms whenever something goes abnormal after delivery or during the process of delivery. Or they will be able to identify early signs of some problem with the neonate also. So these are things which we try telling them, and then then they sit as birth companions, and we are able to empower them with the help of this patient committee members also. Again, we have used the patient and family members committee in the quality rounds, quality and patient safety rounds. We have created a checklist of what they have to see. And based on their ideas, we are able to improve the hospital again. We have used these members in various co-designing programs within the organization. Again, we run various competitions to create awareness for the public, like breastfeeding awareness, or it can be a diabetes awareness program. So for all these competitions, we ask them to be the person who judges these posters and other things, so that they also get involved in this. And again, we have various school projects happening, where we take up students from the local schools and try to teach them about the healthy habits and how to prevent diabetes and other non-communicable diseases as they grow older. So for all these projects, they are also, the committee members are also involved. So we have divided smaller teams within the committees. So some people who are interested in co-designing the website of the hospital, so they are part of the website designing team. Some of them are interested in doing the flyers in local languages, so that the patient education material has to be given to the hospitals. So these are all ideas which I have created and have been working with my own team, and that's how we keep them always engaged.
Fantastic. More for us to learn from. That's fantastic. So I think I might have time for another question. And you shared your insights from the States on quality improvement in the community setting in your presentation, and some of your of answering our questions. But maybe just could you capture the key learnings and the take-home messages for our audience today, particularly as we move to more community delivery of care, given that you deliver in the outpatient setting as a matter of form?
Yes. So I'll try and summarize the key learnings for engagement of outpatient clinics. I'll just probably leave you with 3 points. The first one is the importance of engaging the whole clinic team and improvement. And by team, Dr. Anu reminded me that in our collaboratives, we do have a patient rep that's on the collaborative team, helping us design a sensible quality improvement project where we take into account really real life patient perspectives. So team-based improvement. The second one is making sure that you have a clinician champion at each clinic. And, that's come up. Dr. Anu is a strong clinician champion at her setting. And so you need a local clinician champion. And then the final point is, in the excitement and the passion of conducting a quality improvement initiative, sustainability is sometimes left behind, and making sure that you plan for sustainability, making sure you hardwire some of the changes is really key.
Excellent. Thank you all so much. So I might just ask if any of you have any other closing comments that you'd care to make. Anything you'd like to add?
Okay. So adding on to this patient engagement, when we were thinking of using our patient committee in senior citizen club, so we have formed smaller clubs which make our senior citizens participate in these programs. So we have a knitting club now. So I involve my mother specifically. She is now 85 years old, and she because I made her come because she keeps on falling. She's very prone for fall, and whenever she falls, she comes into the hospital. So I told her, "You are coming for all that. Why don't you come and start teaching our people?" So she was kind enough, and she got interested in doing the crochet work. And because it's a hand-eye coordination, which is very important for the neurons to act. As you grow older, the hand-eye coordination goes away. So to keep the brain active, I have found out so many things for them to work on. So I made her as the chair for the knitting club of the women now. So all 60 plus women, they come and sit with her, and they have some homework to do at home, and they bring to the class to show it how they have done it. So then we have certain things we have a small library where people are able to engage themselves. We have various smaller activities like chess or carom, all these playing things. So for the whole program is run by the patient and family centered committee. So hospital people just facilitate the whole thing. So we try to engage them in all this so that they are also motivated in coming in, and we have given them all quotes so that they can go around the hospital putting in colored quotes. Put as the name is as PFCAC committee members, and so we put them on the website. We ask them to give some small talks. So these are the various ways you can start implementing this.
Wow. And the yoga, you mentioned yoga.
Yeah, so that's really right. So for the senior citizens, what we do every last Sunday in our hospital, it's the day. So where we have a geriatricians taking care of the health, and then we do a health checkup for all the senior citizens who come in. So that part of it is taken care of, and then we have a yoga class happening. We have a yoga teacher coming in and taking a free yoga class for the women, for the men. If they are not able to do it lying down, we have some sitting yoga in the chairs. And then we have a fitness expert talking to them on fitness. And then we have doctors giving them talks, some Q&A sessions where they can talk about their health. We have dietitian giving them some diet tips. So these are various ways we have been engaging this senior citizen clubs in our place.
Okay, and interesting that they come to the hospital this, as opposed to you going into the communities to do this.
So we have these community engagement into the villages also, where for diabetes specifically, we have taken the non-communicable diseases in a bigger way. So last 20 years, every month, the hospital team has been going into one specific village where we partner with the NGOs or the village heads to do the camps. And where we have a puppet show also. So these are real life-size puppets which I have designed, and so the puppets themselves talk about diabetes. So this helps you to engage with the community in the local language. These are all music shows, song and dance shows, which help you to, in various ways, we are trying to engage with the community. So I think you'll all like it when you see it. If I have an opportunity, puppet shows, life-size puppets, all are 6 feet height, so that you can show it to a audience, not
Your mother knits them.
not knitting. It's a huge puppet which was done by a person who had got the President's Award for doing these puppets.
That's just fascinating that you brought health and well-being into it so much. Do you have similar experience of health and well-being in the States and in your line in your own outpatient setting?
Yeah. So my colleagues engage a lot in school-based healthcare and in community care. So, in terms of school-based screenings and community screenings, I've worked on a quality improvement project and improving screening for conditions that young athletes may end up with, problems. So sudden cardiac disease in teenagers, for example, we've been hearing a lot about that lately, right? So sports screening is big, and so going into the community to do sports screening is something that my colleagues and I love to do.
Okay, excellent. So we have covered the full gambit. We won't touch on the health and wellbeing in the Department of Health today.
I made a note to engage my mom in my next quality initiative.
I think those points actually made show the importance of local engagement and creativity and enabling, that kind of just really amazing collaboration between the people experiencing the services, the people delivering the services, and the power of that. And I think whatever is the design in our new system needs to really allow for that. And we need to be able to see it. It needs to be visible how impactful that is. So well done. It's been inspiring.
I have to thank my whole team in the hospital who have been part of the whole program.
Yeah.
So I design it and then they start implementing it.
Okay. We're really getting into it now, just as it's with a minute to go. So I'm afraid I'm going to have to draw the conversation to a close. I neglected to mention at the start that we've just launched our sepsis campaign today, so you may well see and hear from us on social media and on the radio. I think we've got some of the material up on screen, and I'm also going to remind you of some of our national quality and patient safety resources, and encourage you to link in and connect with us through those resources and through our websites. Thank you once again to my very eminent panel for your time and your expertise, and thank you all for joining us.
It was a pleasure. Thank you.
Thank you.
Thank you.